there with you in person. So I want to connect this panel back to an opening comment that Catherine made. We have probably, all of us, had many conversations over the last 3 years, and probably a lot of hand-wringing talking about workforce and workforce problems and workforce shortages. And that kind of situation begets innovation. And so what I would like to do today is we're going to have an opportunity to hear from 3 of our partners. And the way we'll set this up is I'll just orient you a little bit to what we're trying to accomplish. Then I will introduce very briefly our panelists, and then I will turn it over to them. They will speak in the sequence that I'm introducing them. We will have a few minutes to have a conversation that I will ask each of them, and then we're going to open it up to a chance for you to have an open forum with them, to ask questions, hear answers, ask a little bit more detail perhaps about what they presented. So the goal that we're trying to do here is we have 3 partners who are going to share with us an overview of the creative, innovative pathway efforts that they've taken. And our goal here for you is to, hopefully this will spark some ideas for you, for your organization. And at the very least, we imagine you're going to be inspired by what's possible in a setting when it feels like things are very much constrained around our workforce. So our first presenter is going to be Al Rowlett, who's the Chief Executive Officer at Turning Point Community Programs. He'll be talking about the Turning Point Community Programs that's taken to a multi-pronged approach to workforce retention, particularly inclusion of community voices at all levels. Then he'll be followed by Chris Meyers, who's the Chief Clinical Officer at United Indian Health Services, who's going to talk about how his organization has been using hiring preferences to have their medical assistants better represent their community. And then finally, we'll have Nancy Wongvipat Kalev, who is the Senior Director of Systems of Care at HealthNet, who will be sharing about HealthNet's Parent Leadership Training Institute that encourages parents in civic and leadership training opportunities with the goal of creating community and workforce pipelines. So Al, I'm going to hand it over to you.
Thank you so much. And I wanted to verify that you can hear me well. Thank you. Again, I'm Al Rowlett, Chief Executive Officer and President, Turning Point Community Programs. And I've had the unique privilege of being a part of the organization for nearly for 4 decades. And as part of that, had the challenge of trying to navigate workforce issues, development and retention during a period that was unlike any other I had experienced in my career. That was COVID. And we saw that we were in a dark, deep forest, and there was light, but we could not navigate our way there. And so therein lies the illustration that you see here. Next slide, please. I'm going to do some level setting. Our mission is clear: empowering people of all ages. We have 3 very distinct core values: relationships, resilience. I'm so glad that was emphasized earlier, and recovery. And again, we are a behavioral health organization. Our goal is to support people with ameliorating the symptoms associated with psychiatric illness or mental illness, oftentimes exacerbated by the social determinants, i.e., sometimes, again, we work with individuals who are unhoused, who have experienced multiple traumas, or who are experiencing symptoms associated with very unique diseases like schizophrenia that have manifestations that are different given the geographic region that the person lives in. Next slide. We are geographically dispersed, and that's why I wanted to make sure I emphasize that. In the central part of California, and there's some unique and different challenges. Sacramento is not Merced. Merced is not Butte. Butte is not Placer or Nevada. And given the communities that we are in, it also lends to some very unique workforce challenges. And during COVID, it was highlighted by a need for us to shift organizationally. We had a need to hire approximately 20% or over 150 individuals because we had that many critical shortages, not all the shortages, but that many critical shortages. And I began to engage community members who happened to be a part of a project called Confess. And the Confess project was comprised of Black or African-American barbers. And that project emphasized that barbers, baristas, and beauticians had a unique amount of psychological ability to advance psychological safety and a unique amount of emotional intelligence that was transferable to our industry. Or as one barber said, I do a lot of counseling from the barber chair. And we began to think about, how do we talk to those individuals about careers in behavioral health? Next slide. So we did which you've heard a lot, I'm sure, in the course of your career, a SWOT analysis. And I'm only going to emphasize two aspects of it, the strengths. We asked people, what were some of the strengths in our organization? It was very important that we had that available when we began to talk to people who did not traditionally engage in looking at behavioral health as a career opportunity. We talked to those individuals, barbers, baristas, and bartenders, about work-life balance, about cutting-edge opportunities and resources. We were able to help train them in this skill called mental health first aid that they could use. We began to really focus on customer service so that they would appreciate the utility of the behavioral health services in their community. But we also saw that we had some very important weaknesses. We had, from their perspective, a lack of a clear professional development plan that was highlighted earlier. How do I, again, enter the organization in the area that may not be your traditional sort of clinical pathway, and then work my way up? And we did not know how to really adequately address some of the inexperience that our managers had at developing leaders or developing colleagues who came into the organization without the sort of traditional clinical skill set. Next slide. So this is what we did, and we're still working on it, and it is a work in progress. So be kind, but it's a work in progress, because we've never embarked upon an organizational-wide training where we invested in managers, because what we realized is not only did we have a recruitment problem, but it was exacerbated by our retention problem. We were bringing these individuals into the organization, but they weren't staying. And they were staying because of some of the things that I just talked about. So we began this program that is still ongoing called the Fundamentals of Leadership. Next slide. And in this program, we said, okay, what did our community say to us? They said, first, you don't have a real emphasis on DEI. So we developed a DEI advisory board that actively looked at our policies and procedures and said there's a lack of transparency in the organization. People come into the company and they don't know how much they'll be making. So we developed a career compensation and succession plan, CCSP, and we put everyone's salary, we made everybody's salary, including the CEO, we put it and made it very available. We put it out in all of our distribution so people understood these are the salaries associated with behavioral health. And they gave us lots of feedback. They told us where they thought salaries were too low, and they told us where they thought we would emphasize, what we should emphasize. As also a part of that CCSP, we made some very discernible career ladders that people could take to move up in the organization. We want people to understand, if you entered the organization, there was a lattice that would result in you moving up and advancing in the company, and that we were going to be very transparent about that. And that for those people who individuals that made a commitment to the organization and our mission, vision, and core values, we were going to invest in them educationally. Yes, invest. Help them go back to school and matriculate if that needed to happen. through their education, but being very transparent about that, and then advancing those individuals, especially those individuals from underrepresented communities, into leadership positions. We are doing that now, and we began to invest in the managers, because the managers, they understood and appreciated the importance of advancing emotional intelligence and psychological safety in the workplace, but being able to do that with this group of colleagues, they were not as good at that as they should have been. And so, next slide. We began to integrate back to that previous slide, we integrated the training. We did some very unique things and challenged their skills. We did some skill enhancement. We did some strategic visioning. We began to highlight the importance of making sure that people were able to inspire colleagues, because there are aspects of behavioral health that are uniquely challenging. And that when individuals came to work and they demonstrated behaviors that were different than your traditional professional, and they wanted to know how much they make, they wanted work-life balance, they wanted you to believe and understand that it was a privilege for them to come work for you versus you, it was a privilege for you to have them versus them have you. And that we had to shift our mindset, and that shift in thinking of the mindset and being able to work with managers, that was a challenge. And then the other ongoing challenge that we have is to be able to take what is a traditional HR approach and decentralize strategies so that our HR approach is no longer an HR approach, but a Department of People Operations approach. That's what we did. We renamed it, and we decentralized those strategies into the work sites. Next slide. We get feedback. We look at really soliciting colleagues very aggressively to get their feedback regarding if the strategies are working and making a difference. Next slide. Our goal is to train leaders so they can more effectively engage colleagues, so that the colleagues are able to identify and implement initiatives that advance health equity. And we're getting there, but you absolutely, in order for us to achieve retention, we have to continue to invest in our leaders and are really helping our leaders to appreciate the importance of diversity, equity, inclusion in the workplace. That's my 10 minutes. Thank you.
Thank you, Al. I think we have Chris up next.
Yeah, good morning. Let me figure out screen sharing real quick. Am I able to screen share? There we go. All right. Can everybody see okay and hear okay? Good. All right. And I apologize for my voice. If this was 2 days earlier, I probably would not have been able to participate. I'm coming over some laryngitis, not COVID though. Appreciate it. First, I want to point out the slide that Catherine shared earlier, just shared so much and really hit, at least to me, the root of some of the issues we're having in California. And I wish I had that slide when I was preparing my presentation. I'd have more ideas. But I'm Chris Meyers. I'm the Chief Clinical Officer at United Indian Health Services, and just going to share a couple simple pipeline pathway programs that we created to help close some gaps with our MA workforce. First, a little bit about United Indian Health Services. So we primarily serve approximately 12,000 American Indians over 7 clinics in Humboldt and Del Norte County. We have many clinical services, but when it comes to medical, it's pretty much bread and butter family medicine, from OB, all peripartum care, newborns, pediatrics, all the way through end of life, including all the chronic diseases in between. We also have medication-assisted therapy, psychiatry to a small degree, and some subspecialties like a cardiologist periodically. So the problem that we were facing, and this was actually pre-pandemic, but just sort of worsened by the pandemic, was that we were struggling to fill vacant MA positions, and partly due to those positions requiring a certification. And this shortage of MAs or lack of applicants to fill those vacancies led to this workforce reduction with the MAs that led to burnout amongst the current staff, including, the providers, the nurses, as well as the MAs. And with this attrition exceeding retention and our recruitment efforts not keeping up, we were facing this downward spiral of burnout and people leaving. So we shifted our mindset and essentially allowed non-certified candidates to apply for these MA positions. And we did so by first sort of shifting the dynamics in HR and utilizing more motivational interviewing techniques so that we could better assess the fit of the candidate for our organization. We were sort of in a position where we had so few MAs that we were just hiring anybody that applied, and that created additional friction. So we sort of put the brakes on it. We're going to really take our time, make sure we have good candidates before we hire. And with this hiring of non-certified candidates, we had to develop some sort of pathway for them to gain certification. And those pathways came through two programs that we developed in partnership with CRIB and the College of the Redwoods. So CRIB is I'm not sure exactly how they would consider themselves, but they advocate, they share resources, they have training programs, and they offer technical assistance for tribal healthcare organizations in California. And through this partnership with them, we created a pathway that once a non-certified MA was hired by us, they would assist in those MAs completing the required training and gaining certification, utilizing our internally developed on-the-job training. With College of the Redwoods, just by serendipity, they were looking for teaching sites to allow their MAs to gain clinical hours. So they helped us to improve and update our internal training program. And they also preferentially steered American Indian students to UIHS for their externship. And this sort of helps bolster our native workforce. So just some minor details on the CRIB program. The students essentially have an online application process. They're approved within 2 weeks. And from there, they get access to course material, online platform. They pay all of the tuition. If the student needs a computer, usually a Chromebook, they'll provide the Chromebook. If they're not already hired by UIHS, they'll offer a living stipend. If they're already hired with us, our payment to them sort of covers that. With the College of the Redwood program, we do a meet and greet with each class of MAs at College of the Redwoods, and we share with them some of the details of our unique client population, the communities that we serve, some of the resources that UIHS has, as well as the services that we offer. And like I mentioned, College of the Redwoods preferentially matches externships with American Indian students through our externship. And we typically take one student at a time. The externship's about 13 weeks. So we see 4 to 5 students per year. And anecdotally, about 80% of the students that go through this program end up applying and being accepted at UIHS. And we found this program to be especially beneficial for both organizations, really. But we look at this as sort of the ultimate interview process. We learned so much about these students, what drives them, what their interests are, you know, if culturally they're a good match for our organization or not. Just some details on the externship. 13 weeks long. They learn, you know, all about what it takes to be an MA, including how to obtain vital signs, rooming patients, proper cleaning, how to administer vaccines. They learn a lot about medical terminology and how to document properly. We rotate them through a variety of teams so that they sort of learn better how to deal in the different dynamics of teamwork in healthcare. And then with the Redwood program, there's classwork associated with it. There's guided monthly labs online, as well as a forum online. Ultimately, at the end of the externship or the coursework through CRIB, there is an examination required to become a certified clinical medical assistant, and UIHS pays for that for them. They receive a certificate and are required to maintain their continuous educations and renew every couple of years. So really, you know, the end result of these programs is it's really helped us with our hiring preference of American Indians and Alaska Natives, with these frontline staffs to help bolster our Native American workforce. It's improved our relationship with the local college, and we're working for similar relationships with their dental assisting program. And it's dramatically helped to close the gap on the MA workforce. I was querying HR for some objective data to share, but we're really struggling with data collection and utilization. So I couldn't pull any objective numbers, but I can tell you that we're much better staffed than we were before. And that's really it. I think we're going to do questions after, right? Yeah.
That's right, Chris. Thank you so much. I'm going to go ahead and invite Nancy to come on and get your slides set.
Oh, thank you so much. And thank you, Al and Chris. I mean, you both have stood up very cool programs, and I can't wait to see the outcomes of that. Hello, I'm Nancy Wongvipat Kalev. Let me put on the screen share here. Oops, is that better? Senior Director of Systems Care at HealthNet. I've been at HealthNet for 21 years, primarily in program strategy, design, development, implementation within the quality improvement area, focused around our community health programs and culturally targeted programs, you know, around addressing cultural competency, health equity, health literacy, language services. And, you know, many of these programs were quality improvement, sort of, you know, one-time initiatives or pilots. And now we get to do it as a sustainable model through CalAIM. And, you know, and I wanted to share that because the program that, the pilot that I'm sharing is connected to CalAIM. And as you know, CalAIM is, you know, this big transformation in Medi-Cal that's happening. It's a 5-year initiative that started in 2022 that will go through 2027. And a big part of the implementation is really re-looking at the provider network, right? How we are building our systems of care to serve our diverse populations, our most vulnerable populations. And so in preparation for CalAIM, HealthNet, we actually piloted several pilots, you know, to look at various models, and part of that is really looking at how do we build a new sets of providers, as we knew that for CalAIM, we're you know, we mean those we have to work with and really be able to effectively serve those experiencing homelessness, right? Those who are just as well and re-entering from incarceration, kids and adults into the community, you know, those in child welfare, transitioning age youth, right? And so a fundamental part of doing this effectively is ensuring that we're building a network that has trust in the community, who have experience in connecting with the community. And there's a lot of connections to what Al and Chris has shared, really, fundamental in investing in our communities to become part of that provider network. And so, we tested out various models in terms of piloting our doula program or our community health worker programs before CalAIM, became live. And as you know, right now, our community health worker is now a benefit through the Medi-Cal managed care plans. We reimburse for doula services, for enhanced care management. I'll talk a little bit later on. Whereby the network does not have to be that traditional, medical nurse or, even a social worker. They could be those from the community who then can apply as part of an organization, whether it be CBO, to become a provider. So now there's a pathway, right, to be able to bring on various types of providers to become part of the Medi-Cal provider network. And so one of the programs that we looked at was around addressing children and youth and family needs, looking at a trauma-informed approach, trying to address our ACEs, right? We knew that, especially with CalAIM, all of our populations of focus are managing difficult life circumstances. They have high ACEs. And so we partnered with Lead for Tomorrow, which is a nonprofit focused on peer-based education and support, but also trauma-informed leadership development. And what they do is implement a two-pronged program, which we piloted. And the second part is what I'll be sharing with you today. But Family Hui is a positive parenting program whereby we engage parents to become part of a 12-week positive parenting program. And then out of that session, we identify parents who will become the potential leaders, right? And then engage and invite them to be part of a leadership training program. And this is what the Parent Leadership Training Institute is, in partnership with Lead for Tomorrow. And let me just share. And as I went through, or I saw Al and Chris' presentation, I realized I didn't have any background on HealthNet, so I just stuck an old one in here. So there might be some outdated information, but essentially HealthNet is over 40 years old. We serve a little over 2 million Medi-Cal members, but we have 3 million members statewide. So 2/3 are Medi-Cal, over 90,000 providers in our network. So we're truly a network model. We don't, have our own providers like a Kaiser. And so we contract, right? Everything is a contracting model. And we are currently in 31 Medi-Cal counties. You can see, the colors here. And you see that we are called California Health and Wellness in some of our counties. And you can see most of those rural counties and Imperial. And then CalViva Health, we are in Fresno, Kings, and Madera as part of CalViva Health. As you know, in 2024, that's going to change with the Medi-Cal reprocurement, and we'll be in 14 counties. So we'll be out of many of the rural counties, including Kern and San Diego. So with that, a little bit about the Parent Leadership Training Program. Let me move this one. So PLTI is an evidence-based model. So this has been around for 3 decades through Lead for Tomorrow. But this was the first time that we partnered to bring it, to our provider stakeholders. And we particularly partnered with First 5 Sacramento to fund Lead for Tomorrow's initiative and implement this effort for the first time just this year. So this is very new, and I'd love to come back to share the outcomes of this. I can share that the first cohort just graduated, but essentially, the makeup of the cohort are those who participated in the Family Hui parenting sessions, right? But in addition to sort of an open solicitation for interest. And so as you can see, for this first cohort, 40 community members were interviewed to be part of the first cohort. 21 were selected based on diverse experience of Sacramento and lived experience. Okay, let me go on to the next. Oops. And I did want to share, there's a lot of themes in what the first two presenters had shared, in that it's really important to first identify. I'm sorry, it's really hard for me to navigate slides and present at the same time, so you're going to see a lot of glitches here. Let me try to move this really quickly. Okay, there. It's important to be able to invest in those who already have trust in the community, right? But part of that is investing in skills building and capacity building. And so part of this program is that skills building component, right? And empowerment. And so you can see what the curriculum looks like in terms of, we do a retreat first, and it's a 20-week program in terms of covering various topics, including diversity, parents as agents of change, and up to civic engagement, to a point where they feel empowered to be able to come up in front of legislature to, let me just look at this. Okay, thank you. So I wanted to share that. Okay, let me get to the next one. And wanted to share our first cohort here. Who had a chance to go in front of the Board of Supervisors to share some of their concerns in the community. So they had a chance to practice, some of that civic engagement and advocacy as well. And then lastly, in terms of potential pipelines, so one of the reasons we piloted this program, and we continue to do so, is to create a pipeline for those who can engage in various programs that touch children and youth and families. And you can see there are several programs and new benefits that have gone live through CalAIM, such as the community health workers, doulas, ECM. Enhanced care management is a key part of that team, is including staff with lived experience. And that's the theme for all of really our programs within CalAIM. A lead care manager can be a community health worker, without any clinical background, and they tend to be the most effective, actually. And then justice involved outreach and engagement is a big part, and justice involved population focus for CalAIM ECM will go live 1/1/2024, and then also looking at our expanded non-specialty mental health services benefits, right, that are reimbursable through the health plans, peer support specialists, and other. Speaking of even what Al had shared in terms of investing in barbers and baristas and bartenders to become behavioral health interventionalists and staff, and this is an opportunity through some of these new benefits, and then street medicine services. So that is what I wanted to share today. Thank you.
Great, thank you, all three of you, so much. So I have one question for you to launch us in opening it up to the audience. The question I have for you, first of all, these were great because they were so creative. They were clearly trying to meet the moment and necessity, and different, but some thematic approaches. So one theme that I noticed that's consistent is really thinking about people who might have the traits and the skill sets from lived experience to bring into a program. So how did you think about that? How did you think about what that priority was and what you were looking for in the group that you were trying to recruit, or groups? So Nancy, maybe I'll start with you, and then Chris and Al, and then we'll open it up.
Sure, thank you. And I would say, within this group, and really with all of our program build, as particularly with CalAIM, employing and supporting staff with lived experience is really is fundamental. And I think in terms of when you ask how do we think about it, how do I think about it, it really should be a requirement, and we are moving in that direction with a lot of our programs. For example, with our justice involved ECM build, we're going to make it a requirement that you have to have staff with lived experiences as part of your team, right? And I think that has to be made clear, and the weight of lived experiences over a degree or educational experience has to be intentionally called out in the recruitment and hiring, in the requirement, to become a reimbursable, program or provider. And so that's really the direction that we're taking to put that weight.
Thank you.
Yeah, we about 2 years ago made an adjustment in our job descriptions where we, at least in the clinical departments, where we just intentionally and meticulously looked through all of them. Some of them hadn't been revised in years, and really focused on the educational and experience aspect of the job description, and just asked ourselves, is this level of degree really that necessary? And for a lot of the positions, it wasn't. So we, on about a 2-to-1 ratio, said, for every year that it takes for a degree, 2 years of lived experience in this field is equivalent. And with some positions, we specifically want lived experience as far as, having a previous substance use disorder or something if we're peer counselors. But outside of that, it was really just a shift away from education per se and more towards experience. And that opened up our applicant pool. And with our changes in slowing down our hiring process, introducing those motivational interviewing techniques, I think our workforce is much stronger just with those two relatively simple changes.
Thanks, Chris. Al?
In addition to targeting people in the BIPOC community who were interested in a career in behavioral health, we said to our leaders, many of whom had some unique skills associated with developing type pipelines, recruitment, retention, and albeit other components of the onboarding or hiring recruitment process, you have to be involved, myself included. And so that challenge was not just implied, but it was very clearly, tangibly evident throughout the organization, such that you saw leaders engaging in recruitment in ways that they had not previously. And that changed how people thought about recruitment. And when the chief executive officer, myself, when I was recruiting someone on a Saturday morning, because we had this amazing job fair in our mall, a part of our campus, and the person realized it was me, they said, I never thought I'd be recruited by the leader of the company. Well, to watch other individuals from our Department of People Operations, i.e. HR, see that being role modeled out, and then helping them to understand some of the unique challenges that service sites experience, and then ensuring that those leaders, those individuals who do that work all the time, spend time engaging service sites became deliberate actions. And then the transparency in how we communicate. We still struggle with that. There are times when we do it really well, though, and you see colleagues understand and appreciate what some of the career pathways are that are available to them that typically they had not considered when they came into our work. And it's important that for people with lived experience or people who are family members, that they see a career pathway, or otherwise they oftentimes believe that they are going to be, quote unquote, in the position that's identified as the consumer or parent or family member job with no career. And that's not the case in our organization.
Fantastic. Thank you. We're going to go ahead and open it up to questions. So if you have a question, you can either put it in chat so we know to call on you. And we'll start with the first one, which is Nicole. And Nicole, if you could begin by introducing yourself and then directing whoever you'd like to have from the panel answer your question.
Good morning. I'm Nicole Howard. I'm with Health Quality Partners of Southern California. The question that I have is primarily for Al. And it pertains to my organization, Regional Consortium for Health Centers versus a health center issue. And I'm directing this to you, Al, because I noticed you talked about career ladders. I'm very interested in that. I have program coordinators, program managers. I would like to have senior program managers, and I would like to have a well-defined pathway or requirements of moving from one position to the other. But what is your expertise? And I'll open this up to others afterwards. As far as expectations of staff, like, do you move people along in the career ladder, even if, like, does there has to be a business need? Because that's what I have, a lot of long-term staff that haven't left their positions. I'm really fortunate in that way, but in some ways, it's hard for staff younger in their career to ever move up. So I don't know if there's any expertise that you can provide to me.
So I use the word career ladder. We are transitioning to lattices because we want to make sure that people have a variety of different pathways. And that's the first thing, that we are trying to develop other pathways, because just like with your organization, we have people like me who've been in their role for a long time, and that sometimes people perceive that as an impediment for growth. And those lattices offer other and new opportunities for them to think about and move into. Second, we have a very deliberate mentoring program, where people get matched with a mentor and that person is there to help them not only with their develop and refine their skills, but also to invite them to think about their own career and the possibilities within the organization. And then lastly, we're uniquely challenged in some regions where we have leadership positions where it's hard to recruit. I think our recruiter is even on the line. He'd say, yes, that's true. And we try to get people to think about those opportunities, albeit with their mentor, albeit with other leadership in the organization, albeit in conversations with me. And I remind people that the way I entered the organization is, in fact, somewhat similar to how they have. And I didn't have someone to help develop a ladder for me, but in essence, I developed a career ladder where I came into the organization wanting to be a hospital administrator and ultimately ended up in a clinician role and achieving some level of advanced degree as a result of just my own discovery. Well, if I had a mentor that I could have utilized that could have helped me with that, that would have been phenomenal. And then making sure that those mentors are from diverse communities with a diverse set of perspectives and ideas about what worked and what didn't work. And it's taking off now. It was a little bumpy at first, but we probably have more than 20 to 50 mentors agency-wide, and they are inspiring people to develop career lattices and then inspiring them to really work with their managers and other leaders towards achieving what you just described. And it's been very successful.
Great. Thank you so much. I appreciate that answer and expanding my vision for career lattices versus just a ladder, which there may not be as much opportunity.
Great, thank you. I'm going to invite Michelle, if you could introduce yourself and who you'd like to direct your question to.
Hi, my name is Michelle Wong. I work at Kaiser Permanente. And my question is actually for Chris. I'm interested, you were talking about the pipeline, bringing in non-certified candidates. And I'm interested actually about what you do once they're in. So you'll have a set of non-certified candidates, and then you have also certified candidates as well. And so I'm just curious about, how do you create an environment, or what's your thinking about creating an environment of inclusion for both the non-certified candidates, but for also those that are certified, so that I can imagine there's maybe some dynamics around, or maybe not, around welcoming, different types of people into your organization. So I just wonder, has that been an issue for you, and how do you manage those relationships?
Yeah, I would say that it has not been an issue because when you have such an issue with your workforce, having anybody there that's assisting with the workload, I think everyone's happy for that. But they are treated a little bit differently. Our job descriptions are built and they've got levels, and a level 1 is a non-certified MA. So their duties and responsibilities are a little bit different. They get paid a little bit less. So, our expectation is that they are seeking certification, and we have dedicated time. We have, training opportunities, all the on the job training that are built into our MA program to sort of help them along. But no, there hasn't really been any issues with the relationships between the certified and non-certified MAs. I hope that answered your question.
Yes, thank you. Thank you so much.
Thank you. I want to see if, because I know it's harder for the in-person group, but I want to give you a moment. If you have a question for our LA in-person group, this is a great time to ask it. I'll let you unmute if you have one, or if you want to think about it.
Hi, yes, this is Serene Pagosian of CCALIC. I actually did have a question for Al. I was wondering if there are any specific trainings that you might point to for, I saw in one of your slides it said advancing emotional intelligence and psychological safety. Are there trainings that might help staff with that?
Yes, and I'm not the training director. I get to do some of those, facilitate some of those. And there are trainings. One of the first names that comes to mind for me is a person by the name of Cheryl Crane, who talks a lot about psychological safety and emotional intelligence. And I'm looking for presenter etiquette. I have a book by her on my desk that talks about the importance of that. She does a wonderful, there are wonderful illustrations that provide, that our facilitators use to provide people with an understanding of the work associated with psychological safety. And it's an embedded feature in the fundamentals of leadership training. And we're using, Tim Nolan is the author, and we've been working with him for a year. We will be working with him for a year, on the Essential Handbook for Effective Human Service Managers. And it talks about this notion of psychological safety and why, if you don't promote that, it is a detriment to retention, especially with today's workforce. And we want to make sure that the human beings of today really do have a sense of commitment to the organization. And that's why I showed our slide on vision and mission, because in closing, we discovered that many of our managers had no sense of what the mission and the vision of the organization was. They knew there was one, but they weren't connected to it. And connecting them to that helped them connect new colleagues to that, and then asking them the question, how are you advancing resilience, recovery, and relationships in the workplace as a skill to really combat what I think is the healthcare inequities that many of the people that we're privileged to serve encounter. And that is a component of psychological safety. And then the last point is, because I'm a big fan of psychological safety, as you could tell, we're trying to get people to understand that you want to recraft problems as learning problems. Okay, what can we learn from this? Instead of identifying it as you did something wrong. And so in the organization, the mindset shift has been making an error that's, again, not a volitional error, but an error in sort of execution or skill is something you can learn from versus blaming. And that's been a shift in our organization. We were very good at blaming people when they did something wrong and identifying that in their evaluation. And now we've shifted it to a learning problem, which is a wonderful component of psychological safety. And it is a skill and emotional intelligence, getting people to use what we often describe as their wise mind when you're talking to somebody about errors that they've made at work.
It's fantastic. One last question that I'm going to pose to our three panelists, and that is, and I'll give you a heads up in which order. So I'm going to do Chris, Nancy, and end with Al. And the question is, what's that one piece of advice that you would give based on the fact that you have tackled issues around addressing your workforce shortages? You've given us some creative and innovative solutions that you have. So what's that piece of advice to those of us that are contemplating or somewhere in the middle of that journey? So Chris, then Nancy, and then Al.
I think looking at our partnership with College of the Redwoods, my largest piece of advice is to find a project that's mutually beneficial to both organizations. I think in this case, we're having access to MA students, and we're providing training for their students as well. So with both organizations motivated for success of the program, I think it's almost inevitable that the project itself will succeed.
Yeah, and I think, similarly in terms of reaching out for partnerships, I encourage all of you to reach out to your local Medi-Cal managed care partner. I mean, this is, in helping to sustain and build the workforce, and particularly, non-traditional workforce, right, is really a priority of the managed care plans. There's funding to do this. There's infrastructure to do this. And it's untapped right now by many of our provider communities that are out there and CBO communities.
Two quick components: transparency, making sure that as you market opportunities for individuals who don't have the traditional or ideal work experience, that you be very transparent about the lattices or opportunities that they have in the organization and what the compensation and benefits are associated with that, not just for them, but for everyone in the organization. It results in greater trust, respect, and regard for the people in leadership. And then having people in leadership being involved in all aspects of those conversations, because they get to role model for a department that oftentimes unfairly is targeted and then sometimes is overly siloed. And that's our HR department. And saying, I underemphasized it earlier, decentralizing some of the work that HR does in the area of recruitment and really helping them to engage service sites and people who provide service very actively and soliciting them with questions like, what's caused you to stay in the organization 1, 2, or 5 years? And then you came into the organization not with the ideal skill set, but now you seem to be very committed to a very particular career path.
Fantastic. Well, please join me in thanking this incredible group of panelists. Thank you, Al and Chris and Nancy. And I am going to hand it off to Marie.
Yeah. Thank you so much to this panel. Agree with Sunita. Give us some help in thanking them, putting your emoji skills to work. We are now going to go on a quick break. So feel free to turn your video off